Good afternoon, Dr. Ala. We received Mr. Marlowe molecular testing, and I wonder if I can discuss with you the result of this test.
Sure, but could you just first remind me with this patient, please?
Sure. Mr. Marlowe is 70 years old, a Caucasian man, presented with a weight loss and fatigue. He underwent a CT which showed multiple lung and liver lesions, and the biopsy confirmed it to be melanoma. We sent for him a genetic testing for BRAF, and it came back as wild at the V600 loci. I'm not sure if there is any other test you would like to order before starting his on treatment.
Yeah, sure. Yeah, I think we ought to send for next generation sequence. Do you know what genes we'll be looking for? Mutation testing for actionable mutations is mandatory in patients with resectable or unresectable stages 3 or 4 melanoma, and is highly recommended in high-risk resected disease stage 2C. BRAF mutations is the most common mutation in cutaneous melanoma, and testing is mandatory. If the tumor is BRAF wild type, add the V600 locus, which is classified as a class 1 BRAF mutation, sequencing of the loci of the other non-minor BRAF mutations, defined as classes 2 and 3 BRAF mutations, to confirm wild type status, as well as testing for NRAS, CDKN2A and TP53 are recommended. The different melanoma subtypes are also associated with different mutational landscapes. BRAF, CDKN2A, NRAS and TP53 are commonly mutated in the cutaneous melanoma. On the other hand, mutations in the BRAF, NRAS, NF1 and KIT are commonly seen in acral melanoma, although with lower frequencies than cutaneous melanoma. And finally, mutations in SF3B1 is seen in mucosal melanoma. SMAD4, MH2 domain mutations are observed in about 10 to 35% of colorectal cancers, but not in melanoma.
We are going to start with Mr. Aqil, who is a 40-year-old male patient. This gentleman, 3 years ago, he had a wide local excision and sentinel lymph node biopsy for a stage 2C superficially spreading melanoma of the right thigh. He has been doing well until a few weeks back when he presented with a right upper quadrant pain, and actually he had an ultrasound and a staging including CT scan and chest, abdomen, pelvis and MRI of the brain, and this confirmed only a solitary liver lesion with no other site of metastasis. A biopsy was taken and we are going to review the results today.
Yes, I have the biopsy result here. The biopsy showed a focally ulcerated lesion with 1 mitosis per millimeter squared and moderate tumor infiltrating lymphocytes consistent with melanoma. We also did the BRAF testing and V600E mutation is present.
So, do you have any suggestions?
Some stage 4 patients present with a resectable oligometastatic disease. Surgical removal or stereotactic ablation of local regional recurrence or single distal metastases should be considered in fit patients, as it offers a potential long-term disease control. Although the value of complete surgery or ablative radiosurgery in such clinical setting have not been validated in phase 3 prospective studies, data from phase 2 are encouraging. In one phase 2 study of about 64 melanoma patients who underwent complete metastacectomy, the median relapse-free survival was 5 months, whereas the median overall survival was 21 months. Overall survival at 3 and 4 years were 36% and 31% respectively.
Good afternoon, Mr. Nabil. Thank you for coming today to the clinic. I hope things are okay with you.
Thank you, doctor. Well, I'm doing generally well, except for the usual side effects of the vimorafenib and the cubitinib. But I can't cope with them. I've been doing so for the last year or so, since I was diagnosed with the melanoma. But I'm very anxious about the results of the CT scan. I really do hope that you've got them now.
Yeah, I got the result of the imaging with me now, but I'm afraid that there is some bad news. The imaging showed a progression of the known liver mets. Yeah, this was the bad news that I want to tell you.
Oh dear, I thought I would have some good news, but seems I might have reached the end of the line here, doctor.
Not really, Mr. Nabil. We still have some other options, and remember always that we will be around to help and support.
The second line options for BRAF mutated disease includes anti-PD-1, anti-PD-1 and anti-CTLA4 combination, as well as the addition of a BRAF and MEK inhibitors if not used in the first line setting. The initial FDA approval for pembrolizumab was for patients with metastatic melanoma who have disease progression after BRAF inhibitor if they were BRAF mutant and ipilimumab. In 2015, the FDA expanded the label to include the approval of pembrolizumab for the treatment of patients with unresectable or metastatic melanoma regardless of the BRAF mutation status.
Mr. Samir, thank you for coming to the oncology clinic. How are you today?
Well, I could have been better, of course, doctor, if I wasn't diagnosed with this cancer, but otherwise I'm okay. Thank you.
Yes, I understand. So, as you know, we have diagnosed you with stage 4 melanoma, and we found that the disease has spread to the liver and lung, and this was proven by biopsy. We also did further tests, and we found a mutation that we call BRAF V600E, which is the most common mutation in melanoma. And I think we could have we could offer you various options of treatment.
Oh, that's great. That's encouraging, doctor. Thank you.
But before we talk about the treatment, is there anything that you suffer from you'd like to tell me?
Oh, yes, I do. I do suffer with multiple sclerosis and high blood pressure. Are these going to be a problem for my cancer treatment, doctor? The current first-line standard of care treatments for unresectable stages 3 or 4 melanoma are PD-1 blockade using nivolumab or pembrolizumab, PD-1 nivolumab combined with CTLA4 blockade, ipilimumab, and BRAF inhibitors such as vimorafenib, dabrafenib, and encorafenib combined with a MEK inhibitor such as cobimetinib, trametinib, binimetinib in BRAF V600 mutant patients. The combination of BRAF and MEK inhibitors are preferred in patients who need a rapid early response. For those who do not have a contraindication to immunotherapy and carry a BRAF mutation, they can now be offered triplet therapy with atezolizumab in combination with cobimetinib and vimorafenib. Approval was based on the IMspire 150 study, which showed a median progression-free survival of 15.1 months in the atezo arm and 10.6 months in the placebo arm. With our patient's history of underlying multiple sclerosis, offering any type of immunotherapy would be a bit risky. However, even if this patient had been a candidate for immunotherapy, it is unclear if the benefit of an upfront triplet regimen is better than sequential therapy of BRAF MEK inhibitor as first line and then offering immunotherapy as a second line treatment.
This is Acting for Clinical Education. Like, share, subscribe.
Don't forget to check the resources down below and join us every Thursday 8 p.m. for more videos.